The title of this session is going to be potpourri, mainly because it's hard to encompass all three of the topics into one major heading. But they're actually three very crucial topics, and I think ones that it's certainly worthwhile sticking around to the end for. First is going to be Nancee Jaffe talking about nutrition and GI disorders. She earned her master's degree in nutrition at Cal State Los Angeles, then completed her dietetic internship at Cedars-Sinai and UCLA medical centers. She joined our division in 2012 and works with patients having all types of GI disorders, including celiac disease, inflammatory bowel disease, short gut syndrome, and then irritable bowel syndrome and any other functional GI disorders. I actually remember the first time that she spoke to us at our weekly GI case conference, and we were really all wowed by her knowledge as well as her ability to take care of these patients. And I feel very fortunate to have her as a colleague, and I'm sure she'll impress you as well today. Thank you.
Good afternoon, everyone. I'm very honored to be here speaking with you. My name, as Kevin mentioned, is Nancee Jaffe, and I have the honor of working with all of the doctors that you heard speak so far today, as well as the other doctors who are part of our Division of Digestive Diseases here at UCLA. So I was given a very big topic, which is nutrition in GI disorders. And as you can imagine, we could talk about anything from celiac disease to IBD to gastroparesis or eosinophilic esophagitis. But what I chose to do instead with my 20 minutes was to really focus on four kind of basic but big topics in GI that I can tell you make up a huge volume of the patient population that I see in my office every single day. So the way I like to go about this is I'll talk about each one of the topics, and while I'm doing it, I'm going to give you some what I call doctor tips. And what I mean by that are hopefully things that you can take directly into your clinical practices and use with your patients. I find that nutritional tips can really help patients to feel like they have some sense of control over some of their very difficult disease states. And by giving them these little pointers can be very useful. It can also help you to understand when it might be useful to send your patient to someone like me who specializes in some of these harder GI disorders. So the first topic that I'd like to focus on is reflux, GERD, and you heard Kevin speak about that earlier today. Most of the symptoms that you see on the side, I'm sure you're very familiar with. I'm sure you're also very familiar with most of the dietary issues or trigger foods that can go along with reflux. The reason why I feel it's so important to bring this topic up is not because you might not be familiar with these foods, but more because what I've seen over and over again is that this information is not being conveyed to patients. So they don't have a full understanding of all of the different triggers, both dietary as well as lifestyle changes that could be affecting their disease states. I can tell you that I saw a patient about 3 weeks ago who was already on a double dose of Prevacid. She was on Zantac. She was not getting any better. And we went over her diet history. We realized that she was putting a squeeze of lemon in every glass of water she was having throughout the day, which ended up equating to about 1.5 lemons, whole lemons every single day that she was putting into her body, and these were increasing her symptoms. And as soon as we removed that, the medications were working better for her. She was able to feel a lot better, and so little changes like that can make a really big difference. So in terms of my doctor tip for reflux, it's that a handout can actually be really useful with this patient population, and making sure that you get these different trigger foods as well as lifestyle changes, simple things like raising the head of the bed, having smaller, more frequent meals, not eating too close to bedtime or staying upright, losing weight being a huge one. All of these can make a big difference for your patients. The next topic I want to focus on is IBS, which you've already heard a lot about from Dr. Connolly today. We know that gas and bloating is an absolutely ginormous topic, and unfortunately, it's not quite so easy to give a handout to your patients when it comes to gas and bloating. We know that gas and bloating can come across many different disease states and can have many different contributing factors. So working in an individualized manner with each one of your patients who has gas and bloating is really important for making sure that you get to kind of the crux of their issue. There are two main reasons why we see intestinal gas. The first one being air that's ingested. So you can see there's lots of different ways that your patients can be taking in excess air, whether it be through chewing gum, using straws, or smoking. And by kind of changing some of these behaviors, it can really help with symptom management. I have to say that my patients who come in and are belching and burping the most tend to be the ones who are the most stressed out. So if you simply help your patients to understand their own anxiety levels, talk with them about mind-body work, meditation, breathing techniques, it can actually really help with their gas and bloating and make them feel a whole lot better. We know that the other reason why patients usually have intestinal gas is because of the natural breakdown of certain foods that they're digesting. And generally speaking, these foods fall into the category of sugars. So we know that bacteria like to eat carbohydrates, and so the sugars tend to be the biggest problem for our gas and bloating patients. So you can see the four most common problem sugars listed here. We've got our raffinose stachyose, which I like to call the Beano sugars. So we know that Beano contains the enzyme alpha-galactosidase, and this enzyme can actually help to break down raffinose and stachyose, which is found in foods such as beans, but also in a lot of our vegetables, some that you wouldn't think of, such as mushrooms, and then some of the obvious cruciferous vegetables such as cabbage, Brussels sprouts, broccoli, and asparagus. So one first-line treatment, or one of my doctor tips, is start with Beano. It's a really easy thing that you can give to your patients that can really control a lot of their gas and bloating. The population you cannot use Beano with is the celiac population, as it contains wheat. So be very careful about recommending Beano to this population. The next sugar, which is one that I think most of you are probably very familiar with, is lactose, and this is the one that's found in our dairy products. We know that by simply stripping down lactose, a lot of people are going to do better. We know that about 50% of people in the US suffer from some sort of GI distress when it comes to lactose, and we know that certain ethnicities are at a much, much higher percentage, as you heard earlier. So this is a really easy thing that you can do for your patients, is to have them remove dairy for 2 weeks. They'll see difference. And especially if you have them remove the ones with the highest amount of lactose, which are our milks and our ice creams, things like hard cheeses and fermented yogurts, generally speaking, have a very low amount of lactose and don't have to be removed from the diet. The next one is fructose, which this one is a much harder sugar to work with because, as you can see, it's found in lots of different things. It's found in a lot of our different fruits and vegetables, but the biggest culprits are in our high fructose corn syrups or corn syrup products. But really the biggest place I see it is onions and garlic, and that's an area that a lot of people don't think to check out, but simply removing onions and garlic from the diet for 2 weeks can also make a big difference in terms of how your patients are feeling in terms of their gas and bloating symptoms. And finally, looking at sugar alcohols. So sugar alcohols are sugar alternatives that taste like sugar in the mouth but do not act like sugar in the gut. We know only about 30% of these sugars are actually absorbed, which means that the rest of them are moving through the system quickly, they're taking water with them, they can cause a lot of gas and bloating and a lot of diarrhea. And you can see these are the ones that end in OL, such as sorbitol and mannitol. The place we need to be looking most for these products are in our sugar-free products. I mainly notice this in the diabetic population, or the populations that are chewing gum or using mints a lot. So when you're working with your diabetics and they're telling you that they have a lot of gas and bloating and they have diarrhea, metformin, of course, is one of the first places you want to look. But then next to that, I find that diabetics like to use a lot of syrups, maple syrup on their pancakes, and this is the biggest place where I'm finding these sugar alcohols are in these diabetic syrups, but they're also in chocolate bars and cookies and cakes and all of these different diabetic products. This is also a place where you can consider using a broad spectrum probiotic, using one that has at least 15 billion strains of bacteria, and also looking at 10 different species of bacteria can really be useful in kind of helping patients to get their microbiota in track. So Dr. Connolly had mentioned the low FODMAP diet, which some of you may have heard about. It's getting a lot of buzz lately, especially in the past decade. And we know that it's a very useful diet. The studies show us that about 70 to 75% of IBS, especially diarrhea predominant cases, are going to benefit from being on the low FODMAP diet. We also know that it can be very useful for SIBO patients in conjunction with the antibiotics, because you're basically starving the bacteria of a desired fuel source while you're killing them with the antibiotics. So using those in combination can be very useful. But it's a very difficult diet to follow. So just so you can see why it might be so difficult to follow, the low FODMAP diet is basically stripping the diet of five specific types of sugars, which you can see listed at the top as lactose, fructose, fructans and galactans, and polyols. And it's found in a wide variety of our fruits, our vegetables, our whole grains. And so following this diet can be incredibly difficult, which is why it's not a first-line treatment for a patient who has gas and bloating. In my practice, it's not even a first-line treatment for all IBS patients, because we have these other aspects that we can look at. So my doctor tips for gas and bloating is think first-line treatments first, the Beano, maybe even Lactaid, removing dairy from the diet, cutting out garlic and onions for a while, making some of those lifestyle changes that have to do with swallowing in excess air, trying a probiotic. If you notice through a diet recall, or you have a patient with IBS-D who has a lot of problems going on, when I have a patient who has a lot of pain, alternating bowel habits, and gas and bloating, usually the low FODMAP diet is a good one to go to. I just like to make sure that there isn't an easier treatment first, because I have celiac disease. I know how difficult it can be to follow a complex diet. I wouldn't want to have to follow this diet. So it's important that we really make sure we're not just putting every patient on it without really making our taking a look at what their diet really needs to be, and making sure that we're putting the right people on the right type of diet. So before I move into my next two topics of conversation, which are the diarrhea and the constipation, I think it's important to have a fiber talk, because there's a lot of confusion that goes on around what fiber is. And I have a lot of patients that come in and say, my doctor told me not to eat any more fruits and vegetables. Or they say, I'm supposed to up my fruits and vegetables, but they don't really understand what has fiber, where it comes from, and what the different types of fiber do in terms of the body, and especially in terms of the bowel movements. So when we talk about soluble fiber, the key things to think about are that it forms a gel in water. So we have our example of oatmeal up here. So you can imagine, that when you add water to a bowl of dry oats, it plumps up and absorbs all of that water. That's the perfect example of soluble fiber. And so what we can do is we can talk with our patients about this gel-forming property. We know, that it helps to bulk up the stool, and it slows down fecal transit time. So the different fiber supplements we have right now that are soluble, all of them are Consul, Metamucil, FiberWell, and Benefiber. And the truth is, some of them are psyllium husk, some are oat fiber, some of them are wheat dextrin. And so we have to be kind of careful about which ones we offer to which patients, knowing that psyllium husk is best for those patients who have the dry, hard, pellet-like stool to help flush those from the system. And I'll talk more about that when I talk about constipation. Some of these other ones are better at kind of just helping to bulk up the stool and form the stool. In terms of insoluble fiber, we want to use that more for the constipation, because none of that fluid is absorbed by insoluble fiber, which means that that fluid is left in the colon and in the stool to help keep it soft and malleable so that it's easier to pass. It helps to move waste quickly through the colon, and this is what our constipation patients are looking for. So the two different supplements that fall in this category are Citracel and Fibercon. So in terms of, I got one, thanks. In terms of diarrhea, this is really kind of a generic slide. This isn't going to be applicable to your C. diff patients or your short bowel syndrome patients or the ones who have post-infectious diarrhea. We kind of need to go broader when we look at that, or more in depth actually when we look at that. But this is more for your patients who are having fecal incontinence or they're having loose bowel movements, and you want to try and give them something that can really help them to control that scenario. One easy intervention is looking at the brat diet. If you have children, you've probably heard of the brat diet. This is what we like to give to little kids when they're having lots of diarrhea, because these are the foods that are easiest for people to take, and it also really helps to absorb that excess fluid that we see with these increased bowel movements. So those are our bananas, our white rice, our applesauce, and our white toast. You'll also see the foods that are listed below. All of these have one thing in common: they're all soluble fiber. So again, we're focusing on these soluble fiber foods to make sure that we are bulking up the stool. We can also help our patients to understand foods that are more likely to contribute to loose stool or loose bowel movements, foods that they can avoid. We know that caffeine can help people to have their morning bowel movement, but if they're continually having caffeine throughout the day, it can definitely cause an increase in loose stool. Fatty, oily, greasy foods, even healthy oils like olive oil taken in too high a quantity isn't as well absorbed by the body and can lead to increased bowel movements. We talked about certain malabsorptions such as fructose or lactose that can cause loose bowel movements. Insoluble fibers, we had just mentioned, can lead to looser bowel movements, and then of course the sugar alcohols. So my doctor tip when it comes to diarrhea is think brat and think soluble. So if you can just remember those two things, I find that when patients are given tips that they can use instead of things that they should avoid, they tend to react a lot better and they're more likely to give diet a shot in terms of making these changes. So focusing on the positive instead of the things that they should remove. And my final topic is constipation. So in terms of constipation, you heard a lot about constipation this morning. And we know that the biggest two things that we need to worry about when we talk about constipation in the diet is the insoluble fiber intake as well as the fluid intake. These are the two most important things that you can do. I had already mentioned that we want to use insoluble fiber when we talk about constipation, but if your patient is having rock hard pellet-like stool and you give them insoluble fiber, you're going to impact them. So that's not the first thing we want to do with these patients. We want to actually give them psyllium husk. And I know that sounds a little bit off because I just mentioned that psyllium husk is a soluble fiber, but it has this amazing property to gel and get inside of the stool and loosen it from the inside. So if you use the psyllium husk first, you get the stool to become loose, they're able to pass these hard pellet-like bowel movements, then you start giving them insoluble fiber with enough fluid. These patients tend to react better and are able to then start having more regular bowel movements. We know that hydration is a huge part of working with constipation. And you can see the numbers up here are probably much higher than what you're used to seeing, the 11 cups for women and the 15 cups for men. But this isn't just water. This is all fluids that you're consuming throughout the day. So this includes your coffee and your tea. This includes soup that you may have had at lunch. It includes the water that's found naturally in your fruits and your vegetables. It includes water. So the more fluid that we can have our patients take, I often find that the average amount of fluid patients are taking in when they complain of constipation is about 1 to 1.5 liters of fluid per day, with usually very little of that being water, most of it being soda. So if we can just kind of change the mentality of these patients and help them to understand how important hydration is in this process, it can really be useful. I also find that prune juice can be really effective. I know it's kind of old school, but if you have patients do just 1 little tablespoon in warm water first thing in the morning, it usually works within about 30 minutes, and it can be a kind of quick, easy tip to see if they are going to respond to just kind of an easy laxative instead of having to do something a little bit more aggressive. So my take-home message, you can see all of my doctor tips listed here. With the reflux, we really want to focus on getting the patients the knowledge about the different lifestyle and dietary techniques. I find a handout works very well in this case. Gas and bloating, unfortunately, that's not quite the situation, and you really want to try instead removing some of these sugars from the diet, such as dairy or the fructose found in garlic and onions, trying Beano or lactate, maybe even a probiotic. These can be really useful tips. And then if you are thinking of working on with a patient on the low FODMAP diet, I highly recommend getting them to a dietitian who's skilled in the low FODMAP diet so that they can understand how to go about grocery shopping, meal planning, all of that type of stuff that might go into following a diet structure that is so complicated. With diarrhea, we want to be looking at the BRAT diet, soluble fiber, and different types of GI triggers. And then, of course, with constipation, we mentioned the insoluble fiber, first working with the psyllium husk if you've got those hard pellet-like stools, and then, of course, making sure that there's adequate fluid intake. So one final thing is, when should you consider sending your patient to a dietitian or having them work with nutrition services? We know that whenever there's some sort of impairment in PO intake, whether it has to do with some sort of mental obstacle, we find that there's a lot of food phobia that goes along with GI disorders, and helping patients to not hyper-restrict is a really important part of it. Anything that, any case that there's malabsorption, we definitely want to work with a dietitian. If inflammation is apparent, medications alone aren't working, or if overall well-being is being compromised. So hopefully with this information, you'll be able to go back into your clinical settings, work with the patients through the doctor tips, and if you find that those aren't enough, then getting them to a dietitian can be really useful. So thank you for listening. I work at UCLA with the GI doctors. I'm only allowed to see patients who are seeing a GI doctor at UCLA. So hopefully you'll be recommending your patients to some of the doctors you saw speak today, and then they'll get to see me. If not, I do have a private practice in Santa Monica, and there are cards out front. Thank you.